To introduce myself, my name is Mark Osterbury. I'm the Executive Director for the Philadelphia County Medical Society. Again, I'm honored to be part of this 10th annual clinical update in gastroenterology. For those of you who don't know, the Medical Society has a proud tradition dating back 172 years when a group of physicians first came together to improve the quality of medicine and medical care in Philadelphia, elevate the ethical standards of the practice of medicine, and upgrade the quality of education. PCMS, as you know, is a vibrant medical, multi-county, multi-specialty medical society with over 5,000 members. We continue with a proud tradition of helping physicians improve the doctor-patient relationship. I have the distinct honor to introduce our current president, Dr. Natalia Ortiz. She was elected by her peers as the president of the Philadelphia County Medical Society to serve a term from June of 2020 to June of 2021. A very tumultuous time, of course, for the Medical Society and for all of the world. Dr. Ortiz is the first Hispanic women president of the Philadelphia County Medical Society in 172 years. She received her medical degree from Ponce School of Medicine in Puerto Rico, completed her residency training in psychiatry at Temple University Health Systems. She is the current professor of clinical psychiatry and behavioral science at the Lewis Katz School of Medicine, and a medical director for psychosomatic medicine clinic. Dr. Ortiz is board certified in psychiatry, neurology, and consultation and liaison psychiatry. Again, no other time has ever been more important for us to sort of band together. Dr. Ortiz certainly understands the difficulty that individual practices and physicians face. And I'd like to turn it over to her right now. Dr. Ortiz.
Good morning, Mark. Thank you very much for the introduction. Good morning, dear colleagues of Philadelphia County Medical Society. As the president of Philadelphia County Medical Society, I want to welcome to this very important and appreciated program. Philadelphia County Medical Society has represented physicians for more than 160 years as they treat patients, advance science, maintain the standards of the profession, and protect the public health. Thank you for joining us. Today is a very special day. Today we celebrate. It is the 10th anniversary of an extraordinary, informative program, the Updates in Gastroenterology, under the leadership of Dr. Harvey B. Lefton, brings together national experts from the most prestigious academic centers. These illustrious physicians share their knowledge and expertise so excellent care will be provided to the patients. As you know, digestive diseases represent one of the nation's most serious health problems in terms of discomfort and pain, personal expenditures for treatment, working hours loss, and mortality. Up to 70 million Americans are affected by GI diseases each year. Overall, direct healthcare costs for GI diseases are estimated to be $136 billion each year. So today we will hear from the best ways to assess and treat motility disorders, celiac disease, cholestatic liver disease, and inflammatory bowel disease. I want to thank our conference chair, Dr. Harvey Lefton, our speakers, Dr. Henry Parkman, Dr. Anthony DiMarino, Dr. David Sass, and Dr. Shivali Herrera. I want to thank the Philadelphia County Medical Society Education Committee, our administrative staff that works very, very hard, and our sponsors. So it's my honor now to introduce Dr. Harvey B. Lefton. So Dr. Lefton, let me introduce you appropriately. Thank you, Dr. Lefton. You know, very proud of you. 10 years, you know. Wow. So Dr. Lefton was born and raised in Cleveland, Ohio. was the first member of the family to pursue a career in medicine. He is a graduate of the University of Pittsburgh and received his MD from Jefferson Medical College. He has completed his internship and residency in internal medicine and a fellowship in gastroenterology at the Cleveland Clinic Hospital. He then served as chief of gastroenterology at Scott Air Force Base in Illinois. Dr. Lefton is board certified in both internal medicine and gastroenterology. He's chief of gastroenterology at Jefferson Area Health Northeast Hospital and past president of their medical staff. He helped to found and launch GI Specialist in 1976, and he is their current president with senior management supervision of the practice. His medical specialty interests include inflammatory bowel disease and endoscopy. He has a strong interest in teaching, which you can tell, and has been a member of a medical school faculty for his entire Philadelphia career. He began his teaching career as a clinical assistant professor of medicine at the Medical College of Pennsylvania. He has maintained his faculty affiliation and is presently clinical professor of medicine at Drexel University College of Medicine. Dr. Lefton has a strong interest in organized medicine. He's very passionate about it and served as his 151st president of our Philadelphia County Medical Society. He has been a member since 1976. He's a champion of medical causes and continues to serve on the board of the Philadelphia County Medical Society, which we are very proud to have him. In addition, he continues to serve as a delegate to the Pennsylvania Medical Society House of Delegates annual meeting and is the current chair of the Philadelphia delegation. Dr. Lefton has also served on the executive medical board at Jefferson Area Hospital for over 30 years. He has served as chair of multiple staff committees and was president of the medical staff. In addition, Dr. Lefton is past president of Pennsylvania Society of Gastroenterologists and has served on their board for many years. So there's more and more about the Dr. Lefton. So I want to introduce, it is a Renaissance man, academician, writer, editor, community and medical society leader, and family man. So welcome. Thank you very much for these many, many years of dedication and for the celebration today at this 10th year anniversary of the updates of gastroenterology. Thank you to the audience as well.
Thank you, Dr. Ortiz. After that kind introduction, I can hardly wait to hear what I have to say. I want to thank you for your leadership over the past year. As Mark Osterberry mentioned, you're a psychiatrist, and I don't think we've needed a psychiatrist more in the past ever than we did this past year with all the challenges and all the vicissitudes we've had to face. This has certainly been a challenging year. If you turn TV on, you will see that there is nothing but disagreement and disputes. I ask you all to take your masks off now, take in a deep breath, and bask in the glow of your colleagues. We have a great faculty, and we can agree to disagree scientifically because that is the scientific method. So unlike our colleagues in other fields, we can certainly agree to discuss different approaches, and we can look at them objectively. Again, happy May 1st, happy May Day. I want to thank especially Mark Osterberry, Eileen Ryan, and Robert Miyamoto for their work on this. Without them, we would not have had this fine conference that you're about to experience. I encourage you all to join our county medical society, whether you're in private practice or in academic practice. You need a voice, and we are your voice, and we care about your concerns. No other organization in this city has that perspective. And as I say, we've been fortunate over the past year to have the leadership of Dr. Ortiz and to have her navigate us through the vicissitudes of this pandemic and into the future. I want to also thank the sponsors who will be listing, and I ask you please to go on the County MedSite website and click on them so that they know that you've looked at them and that you care. Support from the pharmaceutical industry is the mother's milk of education, and we certainly need their help in order to put programs like this on. As Mark said, please mute your speakers. We know your children may want your attention, but I hope we can do it off microphone. We know your pets may want your attention. Let's do it off microphone also. The classical guitarist Andres Segovia at age 92 was asked once why he still practices and why he still daily practices the guitar. And his answer was, because I'm starting to see some improvement. So I am sure after listening to these great speakers we have today, you will see some improvement in your attitudes towards the celiac disease, cholestatic liver disease, motility disorders of the gastrointestinal tract, and treatments of inflammatory bowel disease. We're honored to have a faculty of this stature with us. Please send any questions you have to the chat room at the bottom of your screen, and we will try to have them answered after each talk. Our first speaker today is Dr. Anthony J. DiMarino. He is chairman of the Division of Gastroenterology and Hepatology, director of the Celiac Center at the Sidney Kimmel Medical College of Thomas Jefferson University. While he could not be with us today, he wanted to be part of this program and wanted to thank everyone who is participating in this. And he has prepared a talk which we are going to present now. And at the end of that, we'll have any questions. So without more discussion, let's get to why you're here. And we will start with the presentation for our colleagues. Robert, you can do your magic with our audio visual computer work.
Good morning. Thank you for that introduction, Harvey. Harvey Lefton has been, in addition to being an outstanding gastroenterologist and president of the Philadelphia County Medical Society in the past, he's a colleague in the Jefferson system. And I am pleased to be here today to talk about a very favorite topic of mine, and that is celiac disease. As most of you know, celiac disease is an autoimmune enteropathy triggered by the ingestion of gluten, which is the protein moiety in wheat, rye, and barley in genetically susceptible individuals. On the right-hand part of your slide are the two important components, and that is that you have to have a genetic profile that's HLA-DQ2 or DQ8 in 95 to 98% of the people. That is a necessary ingredient to having celiac disease. And of course, you have to ingest gluten, and which is not hard to do because it's ubiquitous in most populations in the United States and elsewhere in the world. But in order to develop autoimmunity, as depicted on the left-hand part of your slide, you have to have something that disrupts the intestinal mucosal barrier, or fully 30% of the American population, and we now know it's about 1%, so that's, but not 30%. So have to somehow disrupt the intestinal mucosal barrier in order to develop celiac disease. So the pathogenesis is pretty well known at this point. And as a result, the intestinal milieu, the intestine itself, which has villi as a absolute important part of the intestinal absorption capacity, depicted by my cursor moving up and down, is blunted because of long-standing inflammation and cytokine release in some way as a result of intestinal upset, either by something you've eaten or by some major event in your life. And grossly, gastroenterologists can tell by the appearance of the mucosal folds, particularly in the small intestine. Over time, the inflammation and the cytokine release results in narrowing and minimizing the absorptive capacity from something like here with all these nooks and crannies down to something that's very much akin to just by absorptive surface area depicted by my cursor. Now, what's really important, and I titled this talk The Epidemic, is because of those of you who have gray hairs in the audience watching this today, were taught that it was very rare to have celiac disease, and perhaps as rare as 1 in 10,000. But in reality, as a result of some work that Alessio Fasano has done, he has found that perhaps 1 in 133 patients screened in a bloodletting facility in Maryland several years ago now have celiac disease if worked up, and 1 in 20 if they're relatives of those individuals, or perhaps 1 in 10, or 10% of the American population, if you have a first-degree relative who has celiac disease, may have celiac disease yourself without any symptoms. And that's the key part. In fact, to show you how important genetics is to celiac disease, 70% of twins have shared the disease. How common is it in the United States? As I said, probably about 1% of the American population. And if you don't have, in an audience, a live audience, I ask people to raise their hands right now. And usually, well, 10 years ago, probably a handful of hands went up. These days, a full 50% of people in primary care raise their hands, and certainly gastroenterologists are used to seeing so many patients with celiac disease. But if you don't have patients in your practice today, it just generally means that you're probably not finding patients who are asymptomatic. And it varies across the world to 1% in the US to as high as 2.5% in Finland. Probably a combination of genetics and gluten ingestion. Rare in developing countries, but it's really interesting that for some reason, and that's why we expect it to be more common in developing countries as we go along, because in the United States, using bank blood from the 1950 era compared to what was seen in the first decade of this new century, there's a 5-fold increase risk. The same blood that was collected 50 years ago and then compared to later in time, the antibodies which we have developed now show that there's been a 4 to 5-fold increased risk of developing celiac disease over time. And that's been verified by other studies. So it's really increasing for some reason. Why is it increasing? Well, there's maybe a little more concentration of gluten in wheat. It's been very healthy as a diet to stress cereals and ingestion, particularly at breakfast. There's been a decrease in breastfeeding, which just delays the onset of celiac disease as long as you breastfeed. There's been an increase in synthetic yeast. Yeast is the property of baking that leads to rising of either breads or pastries. And synthetic yeasts are much faster in yielding the rise in the breads as compared to the old sourdough yeast. Sourdough yeast is probably better on your stomach. Synthetic yeast leads to increased production, but increased incidence perhaps. Alessio Fasano, the father of modern-day celiac disease, feels that the pesticides we're spraying our wheat crop may be responsible. They're more antigenic, and perhaps the wheat is less tolerated. And it is known that, for example, the microbiome of individuals who are born by C-section as opposed to vaginal delivery do not share the mother's vaginal tract and the microbiome, if you will, and that seems to protect individuals because for some reason C-section babies are more at risk. So with that being said, how do we diagnose it? How do they present? How are patients in your offices today probably being non-recognized or not recognized for celiac disease? Well, the old classical presentation, as I said, was usually of diarrhea, bulky, foul-smelling stools, which float, and patients complain of bloating and flatulence, weight loss, failure to thrive, growth retardation, and so forth. And anemias are rare these days. This is a passage of stool like this. Sorry for exposing you to that picture early in the morning. These are the old so-called kunkel girls. This is what youngsters look like in the 20s and 30s and 40s. They usually present at a young age with failure to grow and mature in response to whatever they were being fed as youngsters. They have diarrhea, abdominal pain, distension, vomiting, irritability, and the so-called celiac crisis. And these people, unfortunately, were at risk. These youngsters were at risk for dying because they couldn't be fed and mature normally. Nowadays, fortunately, we're seeing youngsters detected earlier, and they can do very well, as depicted on the right-hand side of your slide. Unfortunately, 50 to 70% of patients still with celiac disease are undiagnosed. So how do they present? If they don't have symptoms, the classic symptoms of diarrhea and malabsorption and failure to thrive, how do they present? They present with irritable bowel-like symptoms. And I don't know how Harvey, as smart as he is, probably never had that happen to him. But I've diagnosed people years ago with irritable bowel syndrome, and lo and behold, I thought about, since we've been very involved in the celiac world, about testing him for the newer antibodies, and lo and behold, we found a couple of patients who were labeled as having irritable bowel, in reality have celiac disease. So, or they may have no symptoms at all, some bloating and some irritable bowel-like symptoms of diarrhea and constipation occasionally, or they may have no symptoms. In fact, more and more patients are being picked up because they are they've had a relative who has celiac disease, and we look for celiac disease in that population. So before I go on to help you diagnose the celiac disease, I want to make sure that you're aware of these silent presentations. We do know that iron deficiency anemia, that iron is absorbed in the proximal portion of the GI tract. And if you recall that slide I showed earlier, the absorptive capacity of that the proximal GI tract is markedly affected and decreased, and iron is unfortunately a innocent bystander. It's just not absorbed the way it would normally be. Some of the other dermatitis herpetiformis, I'm going to show you that in just a minute, but 80%, fully 80% of people with DH have celiac disease, yet only 4% of celiacs have DH. So if you have DH, look for celiac disease and expect to find it. If they develop a celiac disease if they develop a DH on celiac disease, it means that they're probably exposing themselves to gluten inadvertently. Aphthous ulcers, osteopenia, osteoporosis, much more common. There's a whole host of neurologic symptoms that accompany, and I'll show that in a minute or two. But I want you to, I put in yellow because I want to make sure that you don't look for just thin people. In fact, at Jefferson, we did a study where 30% of our population of celiac patients was overweight. 12% were obese. This is an aphthous ulcer in the mouth of somebody with celiac disease. Recurrent aphthous ulcers make you think of celiac disease. Dermatitis herpetiformis, DH as we call it, looks like these are vesicles which are raised and they itch or they hurt, and they're on extensor surfaces of your body. When you see it on the back like this, don't think of neurodermatitis, of course, but these excoriations that occur because of the itching and the pain are kind of classic for DH. I like to point to my colleagues in primary care to look at the elbows, because for some reason, DH has a predilection for the elbows. So I always examine the elbows of patients that I see with celiac disease if I suspect the disease. So in addition, autoimmune problems tend to run in families and they tend to run together. So DH is an autoimmune condition, but so is type 1 diabetes mellitus. In fact, in one population, fully 20% of patients with type 1 diabetes in the pediatric group had celiac disease. So type 1 diabetes is an autoimmune condition which may be associated with celiac disease. And in fact, they seem that they share the same gene locus. Sjogren's syndrome, dry mouth or eyes, liver disease, undiagnosed liver disease. In one study, 5% of people with increased LFTs, 5% of patients with increased LFTs on that chem line that we all obtained, with no known etiology, had celiac disease. Thyroid disease, it's virtually 1-to-1. It's very, very common. 20% of patients with celiac disease have some thyroid diseases. Other autoimmune conditions are listed. I wanted to emphasize the common manifestations of the central nervous system and celiac disease. Depression, epilepsy, ataxia, recurrent migraine headaches. Recurrent migraine headache should make you think about the possibility of celiac disease, because once you eliminate gluten from the diets of these patients, they improve. The so-called foggy thinking. Patients will tell you that they have a hard time concentrating. They have a foggy cognitive defect. And for the first time, a group in Sheffield, England has been studying. This is a very recent paper in Gastroenterology, which actually measures the diffusion tensor images of patients with celiac disease as compared to normal. And what this is, I'm not going to make neurologists of you, but it's kind of interesting because diffusion tensor imaging is really a sign of the amount of water through the brain. Our brains have water matter, and it's the most important and most sensitive test for white matter changes. The reaction time of patients with celiac disease as compared to normals is very dramatically different and can be measured for the first time. And in addition to the reaction time, there's anxiety, depression, and white matter changes, which are depicted in these MRIs of patients with celiac disease. What happens is these patients, even if they're on a gluten-free diet, may have some changes in their white matter which improve with a gluten-free diet, but unfortunately, these white matter changes do not go away in time. So it's very important to be thinking about migraine headaches, perhaps epilepsy, seizure disorder, and so forth, as being associated with celiac disease. The other thing is that that I think the aspect that I'd like to leave you with is that after diabetes and B12 deficiency, in fact, celiac disease is the third most common cause of peripheral neuropathy. So if your patients have peripheral neuropathies, it's very easy to think about celiac disease being associated. The other 100-pound gorilla, if you will, in the celiac disease space in terms of association with other diseases includes the fact that malignant complications, and particularly lymphomas, are much more common. In fact, in undiagnosed celiac disease, it may be as high as 50-fold, 30 to 70-fold more increased in the undiagnosed celiac population. But it's still 3 to 4 times more common even in treated celiac patients. So intestinal T-cell lymphoma is certainly associated, and there is an increased risk of cancers, and particularly lymphomas, and particularly gastrointestinal lymphomas, such as small bowel cancers, oropharyngeal cancers, esophageal cancers, and other types of malignancies. Been very well shown over time. So there's a New England Journal article that appeared in 2012 by Alessio, and he found that he listed all these complications for you. And so if you want to associate to review the associations with celiac disease, please feel free to do so by going back to that article or up to date or any research publication. What caught our eye a few years ago was the infertility risk. And it is known that spontaneous miscarriages or abortions are much more common in celiac patients. It occurs, and believe it or not, it occurs in a very high percentage of women anyway, but when you increase the risk of celiac disease, and it's even more a cause of infertility, if you will. Now, we did a study here with Stephanie Molesky, who runs the Celiac Center with me at Jefferson. And what we found is that in addition to spontaneous miscarriages, there is a increased risk of preterm deliveries, delayed menarche, and infertility, even in men, perhaps, but certainly in women. And 7% of married women have trouble getting pregnant, and 40% in some disease, in some populations with celiac disease. So why is it important? Why is it really important for you in primary care and for gastroenterologists who also attend this symposium to make a diagnosis of celiac disease? Well, you certainly can prevent malabsorption, failure to thrive, like those children I showed you earlier, prevent or improve autoimmune conditions, prevent perhaps some degree of gastrointestinal cancers, as I said before, lessen the risk of cardiovascular disease, which has been shown to be increased in celiac patients, lessen the risk of osteoporosis, and perhaps lessen the risk of infertility in young women particularly. So how do you make a diagnosis? It's really easy. It's really easy. And all of you have access to LabCorp or Quest or your hospital labs or any reference labs, celiac antibodies, and you can order different types. Just write down celiac antibodies, and that usually will get the biopsy, the diagnosis for you. And if you have elevations, it's important to do an intestinal biopsy to look at the villi, as I've shown you before. So which test do you do? the TTG IgA is very important, and with about a 95% sensitivity and a 95% specificity as well. So highly specific, highly sensitive. Anti-endometrial antibodies, not so important these days. Deamidated can be obtained, but the old anti-gliadin antibodies, they don't have very good sensitivity and specificity for sure. So if you have elevations, if you're serology, that's a good screening test. And it's, I think, very important to do a small bowel biopsy to confirm the diagnosis. There are some that say you can, if you have elevations, just treat them with a gluten-free diet. The problem with that is gluten-free diets are very hard to stay on indefinitely. And sooner or later, patients usually want to know, whether it be for a year or two later or sometimes 10 or 20 years later. If you find bilious atrophy on a biopsy in the presence of the elevations of the celiac antibodies, it's pretty much diagnostic. A bilious atrophy itself, however, can be seen with olmesartan and mycophenolate or colchicine itself. This is so for those of you who like the trade names, this is Benicar, among other kinds of drugs, but other diseases can mimic gluten villus atrophy. So what's the treatment? The treatment is 100% gluten-free diet, not a day, a week, holiday, or not a couple of days. It's not like high cholesterol or high sugar. It's a lifetime requirement. And if you are on this, it's very, very hard to adhere. Why? Because gluten is everywhere. It's in hamburgers and hot dogs as a filler. It's in cereals, of course, and it's in many sausage and some as a stabilizing agent. It's sauces and meat seasons. For example, gluten does not exist in meat, but many times the sources of meat, particularly steak, have gluten in them. So you have to ask. Ketchups are very common, and it only takes 1/100th of a slice of bread to exceed the gluten concentration that's abnormal for patients with celiac disease. What about eating out? Even, and this is a very recent study that was reported by the group at MGH. Of all the foods tested, they found that about 50% of gluten-free pasta and gluten-free pizza were contaminated with gluten. So even, and I guarantee, if you go to a pizza parlor and there's flour in the air, and you try to preserve the gluten-free nature of the pizza, it's very difficult to do so. So it's not as the message is, if you think it's gluten-free, chances are, even in the best of hands, it may not be. What I'm showing here on this slide is this is a new machine which actually tests gluten at your table side, if you will. If in case you see somebody with something like this, that's their way of testing and telling them whether it's contaminated or cross-contaminated, either inadvertently going out to eat or on purpose. So you have to consider other things that in the patient who's really good with their diet, who has continued elevations of their celiac antibodies, may actually be exposed to gluten in lip gloss or lipstick, some Play-Doh stamps, the underside of stamps, vitamins and prescriptions, particularly prescriptions over the counter. A lot of the generic prescriptions actually have gluten as a filler in those as well. So what's the future hold? If you have a diagnosis of celiac disease in your family, or if you have it yourself, what's the future like? Well, I think it's great. It's quite good. And so the things that we can do is encourage breastfeeding, particularly for the youngsters. As I said, it may not prevent celiac disease, but it certainly will prevent it during the first 6 months or a year or so of life. We can genetically modify the wheat. We have the ability to do that, but GMO products are not well accepted by Americans, at least, and other people as well. What about pre-digesting the gluten molecules, much like we do with lactate for people who are lactose intolerant? In other words, they take the lactate with their milk or milk products. Can you take a pill to break down the gluten in your stomach before it's absorbed? Perhaps. The first shot at this was this Alvine Corporation, and I think Alvine is no longer in existence today. We've done over 10 experiments with different products trying to either break down or prevent the absorption or a vaccine, which I'll tell you about in a minute. And this had some credibility, but it didn't work. So despite what you may read or your patients may read in magazines, oh, this product, if you take it, will prevent celiac disease, there is nothing now. It turns out that a group in Boston has a new enzyme which probably they hope will break down the gluten in your stomach before you absorb it, and it's no longer gluten free. It's no longer gluten containing. I'm sorry, I misspoke. It's no longer gluten containing because it's broken down. Stay tuned. It's several years away from production, but it's in phase 2 trials right now. What about the vaccine? Can you immunize something like some people like you can immunize people against hay fever or ragweed allergy? The answer is no. And the reason I know that is because we participated in a trial with a vaccine to try to immunize people against the gluten. It didn't work. So that's no longer a viable option. What about a new group again in Boston is encapsulating gliadin, or the gluten part of the protein moiety in a negative charged nanoparticle. So that's very interesting and exciting as well, and just getting started. But the one that's further along, and the one that we are very attached to, because we've done now, I think, 5 different experiments with this company, and it's been a whole host of companies, is a compound called lorazepam. And lorazepam is a compound, and I don't even know the company that owns it right now, so just to give you an idea. But it works by keeping the cells together. Many of your patients talk about so-called leaky gut syndrome. Leaky gut syndrome. And what happens is the cells of the intestine separate, and the gliadin, which is the active portion of gluten, goes through the cells. Fortunately, this compound, first in class, works by inhibiting the absorption of the gliadin. So this has been studied, as I said, several times, and is finally in phase 3 trials, which we participate in. In fact, we have almost 20 patients enrolled currently. So if you have some patients who are stable in celiac disease and they want to be tested to see whether or not they participate in this trial itself, let us know. But anyway, all I'm going to show you here on this is a study that we were fortunate to be part of in gastroenterology a couple of years ago now. And all I'm going to show you is that the curves go down over time. What does that mean? They have less symptoms when exposed to gluten in the presence of lorazepam. Why I like it is because it's not absorbed. It works in the intestinal tract. It has no effect on blood pressure, no effect on heart rate, no effect on cholesterol metabolism itself, and so it works in the gut itself. It's very promising, and stay tuned. I don't know where and when, in fact, we'll complete the phase 3 trial, but it's probably in 2 to 3 years away. The FDA has fast-tracked lorazepam, however, if it gets through the process itself of phase 3 trials. So before I close, I really would be remiss if I didn't talk about the fact of there are a host of gluten-related disorders. Gluten sensitivity or celiac disease is on one side, and gluten sensitivity on the other side. And in between, there are different wheat allergies, DH, gluten ataxia, and so forth. But it's important because for everyone who has celiac disease, there are 8 people who swear that they are gluten sensitive. And you, I'm sure, have patients in your offices which tell you that they can't eat gluten. Patients say they can't eat gluten, and if they do, they get symptoms. Well, they may get symptoms just like they get symptoms after cauliflower or Brussels sprouts or whatever. It's just something that they're intolerant of, but they don't get the celiac disease and all the associated problems which can result. Is there really a test for gluten sensitivity? No. There isn't a blood test or a biopsy that can tell us, but it's in a group of folks a few years ago published a very nice double-blind study looking at irritable bowel patients and finding out which were allergic or least sensitive to gluten and those that are not without having celiac disease. So the conclusion was that it is gluten sensitivity is real, because if you measure the pain, the bloating, the gas, the nausea that can result if they eat a gluten-free muffin as opposed to a gluten containing muffin, what is seen in this study, and it's been reproduced now several times. It's a real entity. You just have to stay away from gluten. And in fact, the #1 diet in the U.S. today is a gluten-free diet. In 2016 alone, there was almost $16 billion in foods that are gluten-free. So it's very common these days to obtain a gluten-free diet. On the other hand, there are people who just think that they should be gluten-free because it's healthier. Well, there is no advantage. Trust me. Gluten, if anything, has more fat. Gluten-free foods have more fat, more calories in general. But they seem to be people who say, I want to be gluten-free. And this is a New Yorker cartoon that says, I've only been gluten-free for a week, but I'm already really annoying. We've all been to restaurants where there's somebody appears and say they start a commotion about whether or not the food is gluten-free. But it's not healthier, despite what you might hear. You know, I often show this slide because those of you who remember Kennedy, he was Irish and male and in his 40s, but he had Addison's disease, which is an autoimmune condition. His sister had Addison's disease. He had osteoporosis as a 40-year-old. He had recurrent migraine headaches, and he probably had celiac disease. So in summary, celiac disease, I hope I've impressed upon you that it's not rare. It's 1 in 100 in the U.S. and increasing. It can present in many ways, including diarrhea, but don't look for diarrhea. In fact, probably well over 50% and as high as perhaps 70% of patients these days do not have diarrhea. They have osteopenia, depression, IBS-like symptoms, or they are relatives of people who have celiac disease. They have autoimmune other conditions. They may have a cancer, particularly lymphoma in their history or their family's history. The TTG IgA is the best test. TTG IgA, make sure that the IgA levels are normal, because there is an increased risk of IgA deficiency in patients with celiac disease. So you get a serum IgA level and a TTG IgA level to make a diagnosis. Confirm the diagnosis with a duodenal biopsy with your favorite gastroenterologist nearby, Dr. Lefton or his associates or anybody else in this panel today. If you really are challenged with the case, celiac, we have a celiac center at Jefferson. But don't look for the wasted patient. Remember that you can be overweight and still have celiac disease. The gluten-free diet is the treatment, and there are some new developments along the way. I want to mention Cindy Miller, our nurse who's in charge of the Celiac Center with us in some of the studies. Robin Miller is actually a colleague, and Emily Rubin's our dietitian, but Stephanie Molesky and some of my associates are quite helpful. I want to finish with a really quick, just a slide. So I think you all know that celiac disease is a problem for Chelsea Clinton. Jennifer Aniston happens to be gluten-free for whatever reason. Heidi Collins has celiac disease. Elizabeth Hasselbach and Drew Brees both have celiac disease. Victoria Beckham has a peanut allergy, and as does Serena Williams. Novak has gluten sensitivity. Russell Crowe is a gluten-free foodie for whatever reason. Joey, as is Gwyneth Paltrow, and Zoe DiGiorno has celiac disease. I don't know what Ryan Gosling has, but he's a big fan of eating gluten-free, and in fact, this ad that appeared in his in one of his advertisements says that he'll make sure that you never eat gluten again, ever. And he promises that for his girlfriends. So I want to thank you, and I want to thank Dr. Lefton for inviting me. I hope this has been valuable to you, and I'm sure that Dr. Lefton and the other colleagues here today who can be there. Unfortunately, I cannot be, as I mentioned earlier, but I'm sure we'll answer any questions you have. And if you want to, certainly get in touch with me for any questions you have about today's presentation. I'll be happy to answer. Thank you very much, and have a good day.